Guys, this is Dr. Nesco. I hope you are doing well. We're going to study Toronto notes. But I added uh, some notes from USMLE because the primary amenorrhea in Toronto notes is a little bit um, not understandable because it's in a shape of a tab, and I didn't like it so much. But the information it is the same in a USMLE. You can use it. So, primary amenorrhea, uh, it is when the woman from the beginning doesn't have any menstrual cycle, so there is no bleeding, and the causes are different. The problem can be anatomically, hormonal, or hypothalamic pituitary dysfunction. So, if there is anatomical, there is vaginal agenesis, septum, imperforate hymen, Mullerian agenesis, and Mullerian agenesis is when Mullerian duct is not well developed. That can be a causal problem for the woman. It can cause amenorrhea. And we are explaining like that if the patient have breast and or doesn't have the breast, or uterus is present or not present. So there's different causes for this also, but when the breasts are not present, it means some kind of estrogen deficiency, and estrogen is really crucial for development of the secondary characteristics of the like woman. And the uterus can be absent also. So there's different kind of the causes. In this table we can see the causes like uterus absent. It can be chromosomal, or it can be idiopathic. So it's better to study this table very well. But if you don't do it, we're going for below, and there is some other explanation. Clinical approach. So breast present, uterus present, and history and physical examination will identify the majority of a specific diagnosis. Otherwise, the workup should proceed as if for the secondary amenorrhea. So if there's problem with the hymen, vaginal septum, anorexia nervosa, excessive exercise, and possible pregnancy before the first menstruation can be the cause of that amenorrhea. But if breast is present and uterus absent, there's Mullerian agenesis. It can be one of the causes. Complete androgen insensitivity, and this one is really problem for the male if there is XY chromosome, and it's causing a huge problem. There's testicle for the male, but producing estrogen, and the patient doesn't have any receptor for making a reflex and for making the secondary characteristics of the male. That's why it's a problem, and we have to remove the testicle because of the risk of the cancer. Okay, Mullerian agenesis. So as we said, Mullerian duct derivatives: fallopian tube, uterus, cervix, and upper vagina. The lower vagina originates from the urogenital sinus. That's why it's not included. The patient develops secondary sexual characteristics because the ovary ovarian function is intact. Mullerian duct do not give rise to the ovaries, so the ovary is present. There's no problem with the ovaries. That's why secondary characteristics are present, and the normal production of the what's the name the hormone. Normal pubic and axillary hair is present. Testosterone level are in a normal for male for female. And what's the management? The management is elongation of the vagina for the satisfactory sexual intercourse. So we are just surgically making a vagina for the woman because it's not present. Androgen insufficiency, like receptors or dysfunction. So there's not enough androgen receptors to reply to the testosterone. That's why we have to do like that. In the management, testes are removed, and we are doing hormonal replacement. Estrogen replacing is then needed, as here, and it's seen the removal at the age of 20. Then we are going for breast absent, uterus present. The gonadal dysgenesis, twist, Turner syndrome, and hypothalamic pituitary dysfunction. So there's two main causes. So gonadal dysgenesis, Turner syndrome, lack of one of the X chromosomes, essential for the presence of the normal ovarian follicle. So if one of those X chromosomes are not present, the no normal function of the ovarian follicles will be, and this is causing of the elevation of the FSH because lack of estrogen, and there's no reflex back to the hypothalamus and pituitary. That's why no secondary sexual characteristics. So the management is estrogen and progesterone replacement therapy in order to replace the hormone we needed. Hypothalamic pituitary failure. Uterus present by the ultrasound. Hypothalamic causes of the amenorrhea, stress, anxiety, anorexia nervosa, excessive exercise. FSH will be low. So those causes are reducing the ratio of the FSH. Kalman syndrome is the inability of the hypothalamic to produce gonadotropin releasing hormone, and also nosomia. So in this case, we have to do CNS imaging like MRI, CT scan, and the management will be estrogen and progesterone replacement for the development of the secondary sexual characteristics.